my name is Caterina Galani. I'm the Global Product Manager for Molnlycke. And really, we cannot do it without you. Fighting infections is a big topic. No matter how hard we try, the challenge is out there. Working with you, working with important people like Lillian, help us understand the needs and creating solutions and products for you. Before we go ahead, to introduce you to Lillian and to the amazing data and information that she will share with us, I would like to show you a powerful video which demonstrates what we do every day, how we aim to improve the healthcare services for our patients and healthcare professionals. And it would be great to see you in our stand for our new product, the Hebe Wash. So yes, I'm very excited. Together, let's move to zero.
I was in pain constantly. The repeat surgery was horrendous. I was awake. I felt everything.
I could not return to work as a midwife due to the infection.
I was forced to take 12 weeks off work. It had a huge psychological impact on me, as I thought I was going to die and leave 5 children.
I ended up on ICU and now have PTSD.
I have the long-term consequences to deal with, the physiological flashbacks and the ugly scars that the infections has left.
It became very serious and required 12 weeks of antibiotics. This caused me a lot of emotional stress.
By the time I had gone in on Monday, I had swollen up like a balloon. It just went on and on.
It had a major impact on my life for 8 months that seemed to start with a straightforward procedure.
It changed my life.
I'm sure you found this video very powerful, and this is why we are here. Thank you so much. Now I'm leaving the stage to the amazing Lillian.
Thank you very much, Kit, for that video. And when we all come into healthcare, I don't know about you, but when I became a nurse, I really wanted to make a difference for patients. And so every time I saw a patient who had an infection when I was working within infection prevention and control, or who had a fall when I was working in recovery, or who sadly didn't make it when I was in ITU, that was sad for me. So one of the things that I always used to say to myself is, if it's my mom, my dad, my sister, my brother, how would I want to look after them? Okay, so we are going to be using a lot of these powerful patient stories as we move forward with our surgical site infection surveillance and prevention journey. So a few disclosures. I'm presenting today as a consultant for Molnlycke. So infection prevention and control. It's all about the practical things that we do. And it's about the mindset. We've heard about hand hygiene for a long time. And 5th of May is coming, which is the annual Hand Hygiene Day, where we are promoting key messages that will help us to prevent those avoidable infections. But actually, if we don't work together with all the key stakeholders, we may not always get it right for every patient. And as we enter a new era, especially with surgical site infection surveillance and prevention. I'm here with Kat, and whereas before it would have been unheard of, for me as a professional to be seen to be working with industry because, well, they're going to influence me. Actually, we need to shift from that. I have got lived experience of seeing patients who have acquired infections and they suffered a lot. I've got lived experience of working with professionals who didn't really want to engage with important patient safety initiatives, but eventually they acknowledged the value of it. And we did some fantastic work together to make a difference for a lot of patients and also saved money for our organization. So I say to you all today, moving forward, let's cut out infection together. We've got a new group that we just formed called Surgical Site Infection Prevention, which I'll tell you a bit more about later. So traditionally, we've all been talking about the chain of infection. I'm sure everybody, when they do their presentations, wherever they are, is the chain of infection, okay? And then we've seen, from point prevalence surveys, that actually, respiratory tract infections, about 29% of patients in our settings do develop those. Surgical site infections, about 20%. But what we know is a lot of the times, the point prevalence surveys aren't as good to give us, credible data. We need to do more robust surveillance for all the healthcare-acquired infections for us to know exactly where we are. And if you have mandates and you're supposed to be below a certain percentage for your setting, right? Say you're supposed to be below 1%. For me as a patient, I really don't care. I just don't want an infection. And I think we all need to be working towards zero. And that's why we need to rethink our approach over the years. And we know that millions and millions of people actually die from avoidable infections, and that's just not good enough. So when we focus on surgical site infections, like I said, they are devastating for patients. If someone is coming into hospital to have surgery because they want to improve their quality of life, and then they end up developing an avoidable infection and possibly die from it, that's just not acceptable. So we need to be reviewing again and again, our approaches to how we do things. Prevention is always better than cure. So for us as a new group with a new vision, we are really going to be focusing a lot more on prevention. So when you look at patient experience, of course, sometimes we are thinking about the money that we can save for organizations, but actually for the patient, no one wants to get an infection, and Judith Turner has done a lot of work on patient experience, and sadly, some patients did not realize that the infections they developed were avoidable. They kind of thought, well, actually, the surgeon did everything that they could. It was probably my fault, whereas actually, some of the infections, were contracted maybe within the perioperative pathway. So we need to be working with our patients in understanding their concerns and educating them so they know how to prevent these infections. But also, if they certainly do develop them, then they need to know how to identify them promptly so they can get the help they need. So these figures have already been presented in the video that you watched. So who is at risk of getting those infections? I would say anyone is at risk of acquiring an infection, depending on what is happening along that surgical journey. But of course, there are some patients, who are at that, higher risk of acquiring any infection. In my experience, when I've been doing surgical site infection surveillance and prevention over the years, I think at the start of my campaign, people used to tell me that actually the reason why patients have got infections is because they are high risk. I don't think that's acceptable for you to just say that. You know that they are high risk, so you need to mitigate that risk. you need to do proper assessments at the pre-assessment clinic or at whatever moment you get. Of course, I acknowledge that we can't always prevent every one of them, but the aim should always be 0 for those avoidable infections. If someone has a wound that breaks down after surgery, maybe initially not infected, that increases the risk of them actually then getting those pathogens getting into the wound and causing an infection. So surgeon technique is a big thing, but also what we know is sometimes within the operating rooms, we are not as confident, are we, to challenge surgeons when maybe they are not doing the best job. But also those behaviors and attitudes in the operating rooms are really, really critical for us to keep an eye on, because whatever happens there, if we don't do it right, then it may be late by the time the patient gets to the ward. So it's very, very important for us to also look at data on wound dehiscences and then sort of look back and work with our teams, the surgeons and the rest of the clinical teams, to see whether there is anything that can be improved. So how do we prevent these infections? This is the everyday language. Okay, you've heard it for many years. I'm hoping that everyone in this room has had time to look at the NICE surgical site infection surveillance guidelines. So they look at the pathway, and they've got the best evidence, which is bundled, that we can use for our settings. So it's not new. My problem is we've had this evidence for many years, but we know that patients are still developing those avoidable infections, and perhaps we need to do things differently. So as we enter a new era with surgical site infection prevention, I'm challenging you all to think differently. Well, we've heard about the chain of infection for many years. So can we be a bit more specific when we come to surgical site infection prevention and think about the surgical site infection causal pathway? So we are looking at that cycle of infection, but actually then thinking about the practical considerations at each and every stage along that patient's journey. When I looked at data from UKHSA, you can see that actually for a lot of the hip replacements, knee replacement surgery, the bags are, Staph aureus, which is on our skin. So how can we prevent those? They are obviously preventable. More than 60% of surgical site infections are avoidable. So we've got a solution, and then that's where our partnership, with Molnlycke really, becomes alive, because we've got products that are out there. I'm not selling you the Hebe scrub today because you are already using it. But what I'm saying is when you use this product, can you actually think about each and everything that you're doing every single day, and also see what other people are doing and challenge them if you need to. If you're having gut surgery, for example, we know that, because we already got lots of gut flora, you are likely going to find the gut flora, in the large bowel surgery, wound infections. We've got the information. We need to use that information to actually decide on the interventions that we can use to prevent avoidable infections. So what I would say, to you today is this is just abstract for this pathway. We are going to be doing a lot more work on it, but contextually in your setting, so we can see what needs to be done in your own setting, so we can dismantle that pathway and get it right first time for every surgical patient. So, as I mentioned, Staphylococcus aureus is a problem for us. And if you're going to be asking someone to have a shower before they come into hospital, how good are they with that shower? Are they able to do it themselves? Do they need assistance? Are we asking patients whether they are able, do we have that time, or are we just too busy? the problem is, if you miss that critical moment, then the patient is going to get that serious infection. And with Staph aureus, and including coagulase negative Staphylococcus aureus, we know that we then get problems with the biofilms, which are very difficult to treat. And sometimes for the patients who have these implant procedures, they may end up having to have those removed. And that's just not good enough. So we do need to be thinking about, what we're doing, how we're doing it, and how we're supporting others to deliver the best. Again, Pseudomonas aeruginosa. There's a lot of work at the moment going on in your settings around, the water systems, the drains. There's new information. And in my experience, what we found was the fact that actually for some of the surgical wounds, there was a lot of Pseudomonas, and we wondered where that was coming from. But when you do your root cause analysis or detailed investigations, you would need to find out whether there are any potential sources. Of course, for most of these organisms, they would be on the patient's skin, and that's why pre-operative washing is so important. So, as I said, we are into a new era, and we want to contextualize things. It's good for me to be here today and telling you what you should be doing, but actually I'm not going to be in your hospital. So what we want to be able to do going forward is to say, actually, how is it working on the ground, and how can I support you? How can we support each other, so we can deliver the best for our patients? And again, the data is actually saying that a lot of these surgical site infections, the causative organisms are from the patient's own flora, and we need to be doing more. But actually, with antimicrobial resistance, what we really don't want to be doing is to just, be giving, antibiotics for an infection that could have been prevented, because then we are driving that resistance up. And with the way things are going, the climate, decline, we will find it hard in a couple years' time. So again, just reiterating the message that as we move forward, we want to be able to work together. We want to be able to actually go between those barriers. So for me today, I'm here saying we want to work with you and come up with guidelines or new information that will help you to do the right things, okay? Of course, Molnlycke have got the Hebe wash there for you. Like I said, you already have it, but we have to work together and make sure that you're using it appropriately so those patients don't develop avoidable infections. So this is a busy slide and colorful as well. And I put all the colors and made it busy for a reason. Because sometimes we want the easy life, right? But when you think about healthcare, it's very complex. If you go and challenge someone today who is actually already having serious family problems and they're just hanging by a thread, they've made a mistake, yes, and you go and you tell them off, you're going to just tip them over, and they probably will actually make more mistakes. So knowing that we work in complex systems, we want to also be there to be as supportive as we can. Love, kindness, compassion. You can't go wrong, okay? So back to this, my ideal pre-op skin decolonization bundle considerations. I've already mentioned the risk factors. It's very important for you to consider those and actually think about each and every patient as an individual. What do I need to do for them? And then, of course, in the pre-assessment clinics, the staff need to tailor whatever advice they're giving based on whatever the patient is presenting. For the pre-operative bathing, you want to make sure that you give your patients clear instructions as well as staff so they know how to do a good wash. And so we need to develop more material if you don't have that already. And what I would say actually for surgical patients, they need to have at least a shower before the night or the night before surgery, and also one on the day of surgery. And of course, before that, in general, hygiene is very important. So when they come for pre-assessment clinics, we're already really getting those key messages to them. And then there's a lot on there, but you need to actually make sure that your patients, can understand the information that you give them. I've said that, a couple times already because it's really important. Going forward, we are going to be exploring ways of how we can do this better. Like music, anybody wants to compose lyrics for how to do a good wash? Come and see me after. Okay, so we want to think about things that we haven't thought about before because we know that things are not happening in spite of us having all these guidelines and evidence. Okay? And psychological safety. If I'm not feeling very well and you come and you tell me off in a way that is not going to help me, I'm going to make mistakes. So we need to look after each other on the front line. So very, very important. Like I said, we are going to develop this slide further into many other practical things that you can use on the front line. So of course, with the guidelines at the moment, the WHO NICE guidelines, they do say that, patients should have a wash, minimum soap. We don't have a lot of data to say that, they should use an antimicrobial as such. But when you do that risk assessment, that will tell you in your own setting, what bugs am I isolating from my wounds? Do I need to do something about it? If someone is going to have major surgery, what are the implications of them not using that good wash and then acquiring that avoidable infection and possibly dying from it? So it's all about chlorhexidine. Kate will be pleased to hear that today. But actually, we need to make sure that is being used appropriately. As already mentioned, up to 33% of the population, they carry staph already. And we're shedding, all the skin cells every time. So we need to make sure that actually, our patients are protected from those within the operating rooms or, start the process from before. It's proven. Like I said, this is nothing new. You've used it, for many years. Chlorhexidine for your pre-op skin decolonization, but also for your, pre-op, preparation before the incision. And it's demonstrated to reduce infections. And again, very important for you to make sure that you have reduced that bacterial load to the lowest possible levels. So it's kind of, getting a bit deeper into those practical considerations of, okay, I've got my high-risk patient, they are obese, right? So there's a lot of things going around that patient when they come in. Maybe they're going to have their surgery in about a month or so's time. They're anxious because they're going to have major surgery. Maybe they're suffering from depression. Maybe they already have got ascites. They've got pressure damage. Maybe actually the nutrition isn't good enough. So how good are they going to be in complying with whatever you're telling them to do? So you may find that for this particular patient, you may need to spend a bit more time with them. If you don't have time, we need to be thinking outside of the box on how we can actually make things happen from a health promotion perspective and from the community so we can really, close those barriers. And again, for your immunocompromised patient, you know what's around. So it's not just, yes, the wash, but actually think about that patient as an individual and what assistance they may need. If they're going to have an implant, that implant being infected is a big thing. And we never want any patients to get that. And of course, if they end up in critical care, they are prone to getting other infections as well. How you do your wash is very important, okay? So again, in my experience, what I have seen is a lot of the gut organisms in chest wounds. And I'm thinking, how did they get there? So maybe the wash wasn't done properly. Okay, so very important for us to make sure patients actually understand the order of the washings. Ideally start with the clean areas and then end up with the dirty. So within the intraoperative phase, there's a lot of things, again, that you can do. You've got your anesthetic room, you've got your operating room, you've got your recovery settings. So much is going on. And for a lot of the times, people are under pressure. So you really want to be able to work with them, support them, and encourage them to get, things right, the first time. So again, this is abstract. We're going to be doing a lot more work on this. What I would say is my dozen impactful, reusable SSI prevention moments in the operating room. And this can apply across the whole surgical pathway. And I've put the ticks for the preoperative, side of things, assuming that, by the time the patient gets to theaters, that's already addressed. But actually, it's important for, peri-op or theater staff to actually check and make sure that that has happened. If someone has got a resistant organism, then has the decolonization regime been adequate? Do they need to be isolated? Do we need to do anything extra? Do we need to target our antibiotics better? So a lot of things, to consider. And of course, hand hygiene, very important, because we've got those bags. And the reason why I chose reusable, this is an era where we need to be thinking sustainable. Do I need that? And if a patient develops an avoidable infection and goes back to theater, that's a big sustainability thing for us, and we don't ever want to see that happen. It's lots of damage to the climate and everything else that comes with it. And that's why I've got that reuse as the acronym. But again, reiterating on the fact that when we're doing good surveillance, we want to be able to reduce suffering for patients. But when we collect data, make sure you use that data to inform and improve. When you've done it well, don't stay there. Keep moving. Okay, so you can read through the rest of the ideal stuff. Like I said, we are going to be doing a lot more work on that, but you need to pay more attention to each and every step, because with SSI prevention, it's about bundled interventions. If you've got a very good surgeon, they do a fantastic job, and then you don't look after the wound well afterwards, everything is nullified. So we all need to be connecting and working together and supporting each other. So again, it's all about contextualizing things. This is a practical example of where we have seen a lot of the gut flora being isolated from clean procedures. And that's telling me that something is not happening right, either around the pre-op skin decolonization or how people are actually doing the procedure set up within the operating room is not being done right. But when you see 78% of causative organisms for clean surgery being gut flora, that says a lot, and you would need to review your data. And that's a good thing about collecting robust data, because then you know exactly where you are and use that data to review. And certainly for us, we had to review the whole pathway from pre-op, all the way to wound care to see what was happening. And of course, attitudes and behaviors, very, very critical there. Skin preparation, so again, like I said, chlorhexidine has been proven to be very effective. It's better than iodine. But what we also know is the alcohol is to that effectiveness. So it makes chlorhexidine preparations that are in alcohol more effective than the ones in iodine. So with the alcohol, it dries quickly, but what you also want to make sure you do is for the skin preparation, allow it to dry. Don't, sort of rub it off, because then the bugs, haven't been sorted. Think about the difficult to reach areas. The navel, I think, it harbors a lot of bugs, and a lot of, surgeons have mentioned how that, that doesn't always get washed properly before the operation. So the other things, patient warming is well very important for you to think about that. And there's a lot of evidence actually that suggests that if the patient isn't warm enough, then you're going to have problems. Double gloving, do you need to do that? And what I would say, again, you need to do your risk assessment and think about the sustainability agenda. So what is the risk versus the benefit of you actually, double gloving? But again, if it's going to prevent that avoidable infection, then, based on risk assessment, then that would need to happen. So the patient is now on the ward. The surgeon has done a fantastic job. They need to get up, get dressed, and get moving. Okay. Have you all heard about, Brian Dolan and the NPJ paralysis? Yeah, so we need to get our patients moving. Like I said, in the beginning, it's really all about looking at everything from a holistic perspective. So you can't separate these things. So lots to consider for the wound healing. Of course, there's anesthetic considerations, the patient-related factors that we spoke about, and the surgical considerations. So if you don't look at this, with a bundle mentality, then you're going to have problems. That's why everything would need to be, addressed. Of course, we've got different dressings that are available for high-risk patients as well, so that would need to be looked into. And what are you doing when the patient is on the ward? Like I said, we're going to be doing a lot of work on the ground with a lot of you to make sure that, we address some of the challenges that we have. I can talk about this for a week because I've got lived experience, and I've had patients say how, useful these programs are. So I'm now coming to, to the end of my presentation. So I'll just tell you a bit about, the SSI prevention, which I'm currently chairing at the moment. So we've got a group of people who've come together and acknowledged the need for us to do things differently. So with this group, we've already had inaugural meetings where we kind of explored what do we need to do, how do we move forward. So laws, of interest, out there. We've come up with proposals that we feel will make a difference for a lot of the patients globally. So we're kind of, thinking about the annual Hand Hygiene Day. That's kind of what we wanted to do initially, but we felt that if it's just a day, and people go back to their usual days, maybe not good enough. So we are proposing that every NHS organization, private sector, or every healthcare setting in the world must have an SSI champion who we are going to be working with and supporting so we can give each and every patient an opportunity for harm-free care. Of course, we're going to have to develop some resources that we're going to be using for that, and you're all very welcome to join us, as we get into that work. So who can be a champion? And the reason why we are going for the champion model is because from my experience, it was the champions who actually, led all the quality improvement work, which made a huge difference for patients. So anybody can be a champion. And in this new era, now I'm thinking about that patient who had gut surgery and they develop a nasty deep organ space infection. They have to go back to the operating room for washout and debridement. And perhaps because there's so much pus, the surgeons can't close the wound and they leave it open. What it means is that patient has to go to ITU or critical care, and you have many lines inserted or invasive devices. They may end up with a urinary catheter because, of course, they've lost control of their bladder. And then, they're on the ventilator. So now you are predisposing that patient to other infections. So COTIS, ventilator-acquired pneumonia, the bacteremias, okay? But if that infection was avoidable, we failed that patient. So in our new model, we're presenting this, SSIP mantra where we're saying, actually, if you prevent that one infection, you are preventing the collateral damage. And this is going to be sort of looking at infection prevention from almost a different perspective, especially when you're focusing on surgical patients, and saying, if your boss is telling you that we don't have money to do surgical site infection surveillance because we need to look at C. diff patients, my question to you is, Have you actually, reviewed data for your C. diff patients and perhaps, seen how many surgical patients there are on there? Maybe some of the patients had avoidable surgical site infections. And so actually, if you prevent that infection, you won't have your C. diff as a problem. And that's good outcomes for all our patients, right? So we need to change the mindset, and we need to think in different ways. So a lot of that work, again, like I said, is going to be developed, as we move forward. So what we also want to do is traditionally, like I said, we've had many guidelines and research for years, okay? We now want to go back to those guidelines and say, hey, let's champion for an SSI champion in every setting, so that our organizations can actually give us money, to have someone who will be responsible for this. It's very cost effective, and I've proven it in my experience. So again, you will be more than welcome, to be involved in the development of some of these resources. So my take home today, like I said, very busy slide, but it's something that we're going to be doing a lot of work on, and we're going to be developing that further with, the champions and all of you. And it's all about contextualizing SSI prevention. It's good me talking to you today, but I want you to go there and find out what's happening in your setting, and perhaps say to me, how can we help each other to improve things and support each other? We need to improve bundle compliance. Like I said, with SSI prevention, it's about the bundle. If you're doing your dressing, following all the, ANTT principles, okay, but it's a deep organ space infection, it's already too late. You can't change that. So we need to make sure that the whole pathway is addressed, properly. So in summary, we know that surgical site infections, they continue to cause so much chaos out there in our settings. And if I was a patient, I just don't want to get that infection. So today, in the theme of contextualizing things, I've introduced to you the new surgical site infection pathway or causal pathway, which we're going to develop further. And also, my ideal, this is based on my own experience and seeing how effective it was, pre-op skin decolonization bundle. And we all need to embrace these bundle interventions, for us to again, give those patients, safe outcomes after their procedures. And of course, you've got the products that are out there that you're already using, and that's including Hebe Wash. Let's use it appropriately. I've also presented my dozen impactful moments in the operating room. Again, we're going to be developing this further, so you're very welcome to join. So it is really a new era for us. We're going to be collaborating with a lot of people, and we're going to be looking at the whole patient's journey and coming up with new ideas. So together, let's move towards zero. It can be done.